Hello, everyone. Thank you and welcome to SG Innovate. I think it's been a really long while since we've had our very last in-person event. So we're very glad to have such a good, turnout for today's event, and very excited to have Prof Carl Moons from the Netherlands join us for this event as well. So thank you once again for joining us, despite being, midday today. And I hope you guys enjoy the session. So my name is from SG Innovate. So SG Innovate, we're a deep tech investment company builder, and we build talent and the deep tech ecosystem as well. So we do a lot of knowledge sharing sessions such as these, and we've been doing them online for the past 2 years or more. So slowly we are having a lot more in-person events, so we do hope that you keep connected with us and join us. So before I start today's session with Prof Carl Moons' presentation, I'd first like to invite the Deputy from the Netherlands Embassy here to join us and say a few words.
Thank you, Jin, and it's so wonderful to be back in this room. I haven't been here for 2 years. It's so good to here at the event, and I would also like to thank SG Innovate for the wonderful collaboration we've had over the years. The fact that we're here live is great. But over the past 2 years, we've done so many joint sessions online when we couldn't do anything but online. Is this, yeah. And they've really helped us to reach out to the Singapore community and to link and to network and the Singapore ecosystems. Yes, thank you. I hope this one, yeah, this one's better. So, what do we do as a Netherlands Embassy? We're very much engaged in similar topics that Singapore is as well. We are very busy working together in the field of climate change and thinking about coastal resilience. Something else that we are also working closely together on, and Jin, of course, you will remember, we're working closely on alternative proteins and the future in Singapore and in the Netherlands. And why we do that together, and that is because we can learn from each other, we can help each other. We have our knowledge and technologies. Singapore has knowledge and technologies. We have an implementing and testing environment here, and we can further develop our products here and ensure that they reach the next level. And with that knowledge and experience, we go back to the Netherlands and continue the pathway there. Other topics that we work on together are, for instance, mobility, and of course, life science and healthcare. It won't be any surprise to you that the Netherlands and Singapore are very similar countries. 5.5 million or 17 million people, doesn't really matter too much. We have the same level of development, and we're all facing the challenge of aging populations. And when we look at the short term, we're all experiencing, whether it's in Europe or here in Singapore, very tight job markets. So we know we have to do something. We have to keep healthcare affordable. We know that we need to become more productive or find alternatives to bringing the nurses and employees in to provide the healthcare in new ways. Of course, digitization is something that is very much on our minds that we're working together with, and we'll be hearing a lot more about that later on. What I also think is very important is that with an aging population and with hopefully COVID behind us, we move away from the great pandemic to focusing once again on the non-communicable diseases, the diseases associated with old age, cardiovascular diseases, with it's of course we have diabetes, we have dementia, and we think that as the Netherlands at least, we're very much focused not just in ensuring that people live to an old age, but they age healthily, that it's a quality of life. It's not just adding years, but it's adding good years to someone's life. And I think that is an area that is a huge challenge, and we'll be able to, I think, for the next few years, and medium term and long term between Singapore and the Netherlands, because, for instance, in the field of dementia, a lot of research has been done for decades. And to be honest, there's still so little we really understand. There's some issues a little bit with the sound, but this is also a pitch for an innovation mission that we will be leading into Singapore from the Netherlands later this fall. And this will be led by our innovation team. And perhaps, Jose, you can wave to... So what we would like to do is later on really delve a little bit deeper into opportunities for R&D collaboration. And also G2G collaboration, R&D collaboration between knowledge institutes, but also private sector, to see how we can further our common interest in how to deal with dementia on the research side, as well as how to take care of patients in a manner that remains affordable, that we can also manage with the, what I mentioned, the tight job market. And I think there's a lot that we can learn from each other. And with that, you know a lot about AI, you know a lot about how to deal with topics we don't know about yet, and how to go about that as the ecosystem in healthcare between the knowledge institutions, universities, insurance providers, the government, and how do you actually assess treatments or of the future that you do not know about yet, right now. I don't want to delve into that too much because I'm totally not aware, and you're the expert. So I think I would like to thanking everyone for turning out. It's wonderful that you're all here. My message is that there's a lot we can do if we join forces, and I would like to invite Professor Carl Moons to share his presentation, his insights into AI in healthcare. Thank you.
Thank you very much. Good morning, everyone. Thank you very much for the invitation. My name indeed is Carl Moons. And it's my very first presentation on stage since years. I heard that I know that Singapore and the Netherlands have a long history on economics, politics, as well of course in collaborations nowadays also on healthcare. And I'm very pleased to be invited here by the Dutch Embassy and you, of course. And I was here for a meeting anyhow, so it was a perfect combination for me. Yeah, I indeed had the privilege to be involved in two huge new initiatives, new infrastructures launched by the Dutch government. And I was asked to lead these two initiatives, which are very closely related. One is indeed Health Innovation Netherlands, where I kick off with, and the other one is AI in medicine. I focus on medicine. I am aware of AI outside medicine, but I have my expertise on AI in medicine, in healthcare, I should say. But I start with this one. Now, indeed, I'm a clinical epidemiologist. I come from drug research, but drug research is no fun. It's easy, it's really easy. There's no fun for a researcher to stay in drug research. The real challenge is in the non-drug innovations in medicine. And I'm also was the advisor of the Minister of Health on track and tracing apps in COVID. I think it's called here Tracing Together, TT, yep. And in the Netherlands it was called Corona Melder, and Melder means notification, Corona notification. So I was the chair of that committee, and I'm also the one who's doing all the COVID self-tests in the Netherlands, both in people with symptoms and without symptoms screening. And besides that, just my disclosures, I'm also chair of the Dutch Expertise Center on side effects of implants, things that go in our body for more than 30 days. But let me first take you to the first initiative, is Health Innovation Netherlands, because I think Health Innovation Netherlands is very interesting for Singaporeese companies, innovators, investors, to get to the European, not the Dutch, but the European market, and via that to the American market, because we are very closely related to the US with the FDA, HNL. And the other reason, I think, is that something like HNL, because Singapore and the Netherlands have a small difference in number of people, but it's 17 and 5 million, I just heard, is almost equal. It depends on what I think the unit is we're talking about, but in human beings it's almost equal, apparently. And also because I think that what I just said is that HNL can also be maybe incorporated in an organization like Singapore is. Now, what is Health Innovation Netherlands? For a while, I was invited by, 7 years ago already, by the Royal Dutch Academy of Sciences. I'm not sure whether you're aware of that, but if something royal in the name invites you to become a chair, you always say yes. You don't even think. Royal is yes in the Netherlands. And that's the Royal, let me see where the pointer is. Now, it should be this thing, I think, the pointer. Now, here, Koninklijke means royal. And I wrote this report. It was a report in English, by the way, Evaluation of New Health Technology in Healthcare. And then we came to the message and the notion, everybody knows, medical devices are not the same as drugs. Everybody knows. Doing drug research is set in stone across the globe. Since 1948, we know how to evaluate drugs. It's set in stone, phase 1, phase 2, phase 3, a farming economic report, and then you get market access plus reimbursement. It's easy. Of course, drug innovators say, my goodness, what a system it is, but relatively a simple system. Everybody knows what they need to do at the beginning and where you can end and how it works across the globe. And that's totally different with medical devices. And medical devices are not only the ones that we use, the mouth masks that we're now wearing, it's also a medical device, but also robotics, it's point-of-care tests, it's imaging tests, electrophysiology, it is AI algorithms with software. It's all medical device. And we have the new legislation in Europe since 1.5 years, 2 years actually, and that changed the world. That changed the globe for medical device companies. So we thought these two need to be linked to each other. And how are we going to do this? This is what I just said. Medical devices, there are only 1,200 pharmaceutical compounds that make all the medicine. And their number of medical devices is exploding. It's really exploding. The drugs is nothing compared to medical devices in medicine. So, and I'm not talking about robotics only, because Singapore is also very good in robotics, I know, but it's also about things that go into our body, the implants. Again, my pointer doesn't work, but here on the left upper, on the implants. And it's also about imaging, it's point-of-care testing, it's mobile devices, everything is now on our mobile. And of course, the AI, I'm coming back to that as well. Now, and that's a much more bumpy road for medical devices. You have an idea, there is a prototype. Then here, there's market access. And in Europe, it's called CE. What's actually it's called in Singapore? Is it CE or is it FDA approval? You have an own approval system, I think, in Singapore. Okay, yeah. So that's this. And then people always think that they are there. If I'm on the market, then people with blue eyes in the Netherlands usually come across, try to sell that thing, and try to make people getting that device being used. But that's not the way it works. In medicine it is. If you are on the market, you are in the system and you are being reimbursed. And that's not what devices. You are on the market, but then it's still up to you. So the companies say, why are you not using my device? Whether it's a robot, AI, whatever. And the healthcare professionals and the health insurance companies say, why should I? Is it better than what I do now? I have no clue. They don't need to prove that. To get market access, CE approval, is easy. Technical performance and a little bit other performance, but you don't need to prove the things to get to the market as we require for drugs. And we don't want that, because a medical device doesn't always go into your body, only a fraction. The majority of medical devices is simply providing information to you, to patients, to doctors, to act upon that. That's also a medical device. So you need another system. But that's a very bumpy road. And the CE, the market access, is unfortunately the beginning rather than the end stage, in contrast to drugs. And yes, this is very much heard. In medical drugs, it's much less, but here there's so much tech push. We develop for everything, you and I'm also developing medical devices as an academic. I'm really an academic. I have no conflicts of interest with any company. But I'm very much an academic, and we think we simply change the world. But that's not true. Actually, the patients and the whole healthcare system, the demand is different than the need. And the push is different than the need. And how can we match that together? That's not easy. And there are two valleys of death. You might have heard of them, and that's particular to medical devices. One is from concept to market access, CE, for example. And a lot vanishes. And maybe that's good, because they should vanish. It's also with drugs. But the second one is not good, I think. Because many get to the market, get CE. Actually, I'm not nervous, I'm walking in time. So this is the ID, here is CE, and there is the implementation in practice. And that is also a valley of death, and that's what I just said. Having CE doesn't mean that people are going to use it, unfortunately. So you have to communicate with each other. And the good news would be, if you are here with your ID, with your prototype, that the people who are there already communicate with you, at least communicate, to tell you what they want to see, including patients, including citizens, including health insurance companies, including health professionals, who am I forgetting, including the FDA. That they are over there, are talking with you over here, because then we get a good guidance and get them around one table at the same time for the same innovation. That's not easy, I can tell you. Because we have now a problem with the two valleys of death, and the problem is not only for the innovators and the investors, the people with the money and who make it. No, it's not only their problem, it's also the problem of patients, because many people, these people do very good work. But to get it there, you need them as well. And to get it there, you need them as well, unfortunately. So these three stakeholder groups really need to communicate with each other. Yeah, and that was my message. After that report that I just showed in 2015, it came out 2016. It took me 3 years of my life. Now, I'm not sure whether it's of my life, by the way, but I spent 3 years. I don't hope it actually cost me 3 years of my life, but I'm healthy aging, I hope. I spent 3 years to get us there, to get with the Dutch government, together with the Ministry of Health, he, at the time, it was he, launched that, Minister Bruins, and that is HNL. Let me first show you simply a 2-minute video, and then a few more slides, and then I stop and ask for questions about what HNL actually is. And it is with sound, so let's hope that it works.
During our lifetime, we rely on a range of medical technologies for our health, from heart stents and hip replacements to blood tests, MRI scans, wearables, and medical apps. Medical technology is moving at a rapid pace. However, not all valuable innovations reach the market, and many devices on the market lack clear-cut evidence of their effectiveness. Our society needs to find ways to make sure that health innovations are both safe and affordable, with benefits for their users. Innovators are motivated to create novel devices for patients, but navigating a path from idea or prototype to a safe, effective and successful medical device is often difficult. Health Innovation Netherlands is a unique infrastructure in which all stakeholders active in the field of medical devices and health innovation are present. From patients to care providers, and from health insurance companies to regulators. Our ambition is to stimulate the development of medical devices that are safe and cost-effective, and which have a proven benefit for the well-being of end users. We guide innovators by organising roundtables. A Health Innovation Netherlands roundtable brings all stakeholders together at an early stage of development. The innovator receives detailed feedback as well as guidance on how to proceed. Such critical, in-depth evaluations help to ensure the uptake of effective, affordable and beneficial medical devices. Experiences from the roundtables, together with methodological research, will be used to establish new standards for the evaluation of health innovations. Health Innovation Netherlands, bringing health innovation to the next level.
on www.healthinnovation.nl. And that's indeed what Health Innovation Netherlands is about. And it says Netherlands simply because we launched it in the Netherlands, but it's English. It's open for innovators and investors across the globe. And what actually is the mission of Health Innovation Netherlands? The mission is to stimulate the development and implementation, not only of profitable, but also of safe, valuable, affordable, and particularly cost-effective health innovation. And we're focusing on everything that is not drugs, basically. And that's a big, I know that's huge, but let's see how far we get. And that's what health innovation is about. And this almost sounds arrogant, I understand that, but it's not. It really is not easy to get all these stakeholders around the globe. It took me 3 years to talk with all these people which are on the left. And with the upper bosses of these institutes, and what they told me, of course, Carl, who are you? Why should I, as a chair of the Dutch FDA, as the chair of the insurance companies, as the chair of the patients organization, as the chair of the Dutch medical specialists, why should you sit around the table with an innovator, and they always tell me that they are going to change the world, and tell them how to improve the system? Who are you? And I understood. And I thought I will get that in a year. I have it done. Because the Netherlands is small. We only have 8 university hospitals. Easy job. It's not. So that spent 3 years until I said, Minister of Health, you do it. Just mandate it. Tell them, sit around the table with innovators and make sure that you match not only what they push, but also what we need, and match the two as early as possible. So people who are sitting at this part of the healthcare system move over there. And they move closer, the innovators. And that's what HINL is. And that means that all these people are not rookies, really the top level of all these organizations that are here, medical specialists, CE expert, which means FDA experts, healthcare authorities, like the FDA people as well, but also insurers, entrepreneurs, of course, epidemiologists, HTA expert, cost effectiveness analysis, policymaker, product specialists, health insurance and healthcare institute, and definitely citizen or patient representatives. They're really important nowadays to do this. And that's what we do. So what we do, an innovator comes in on the right side. Then we take that innovator by the hand, check what is the innovation, what is their claim, what do they like to change, what do they like to improve. Then we match the expertise in the Netherlands somewhere in the backyard, because all the hospitals in the Netherlands are involved. So you need to collaborate between the government, the academic institute, the hospitals, and with the investors. We take them for about 1 month or 2 months, we prepare with them, matched what they want, to get a very good proposition. Then they go to a round table, which is actually physical round table. Nowadays we can do it as well. So it was online 2 years ago. We kicked off only 2 years ago. And then we really have all these stakeholders around one table, all together, matched to their innovation. Because not everyone is involved in robotics. So if it's a robotic innovation, you need a robotic expert. Not everyone is involved in AI. If it's an AI innovation, you need an AI expert. So it's all matched. So we have a very big list of people. And then we have this multi-stakeholder round table. It's just 1 day. It's a full day. And then finally, there's a report that is going to the innovator that is matching all the needs and desires and evidence that we as a healthcare system like to see to get that innovation into the system. That's actually what we provide them. So they know at the beginning, not exactly, but they have a very good roadmap what to do. Not just the next stage, but also the stage after that. And the stage after that to get in the end where they want to be. And that's what Health Innovation Netherlands is all about. And here, yeah, it's a little bit Dutch names, of course, but here are all these partners, all these institutes. And this is on the right. There is some pointer. You see it? Yeah. It is green here. There it works, but not there. Anyhow, so this is the companies. This is also the companies. This is the Ministry of Health, also the Ministry of Economic Affairs in the Netherlands, Economische Zaken. So it's actually all the partners are involved and they address their commitment. And I'm dying actually, or longing to do that in other countries as well, because I really think for medical devices, so all the non-drug medical innovation, it's the way forward. We need to do this, because otherwise the system is simply overwhelmed with innovations. Because Ford said, if I asked the human beings what they needed in the early 1900s, they wouldn't say a car, but they would say a horse with a wagon behind it. I know that. And also, Steve Jobs said, if I asked the people whether they want a mobile phone, they would never come up with that. I understand that. But economics is different than health. It's not that companies, unfortunately, dictate how to change healthcare. They try to. I'm coming back on that with AI. But it's not that they need to match what their needs are. So what type of innovations? Now this is what we did already. Actually everything passed the stage already. Both people pre-CE, so pre-market as post-market. It doesn't matter where you are. Actually, by the way, the slides are, unless you want me on the picture. I'm sure you don't want that. So the slides are available and distributable. You can take pictures what you want, of course, but the slides are freely available afterwards. So sit back and relax and just listen. So both pre-CE and post-CE, and the innovators can be the big ones. Philips comes around, Siemens comes around, but also the scale-ups, the SMEs, universities, also a lot of people in the academics develop innovations themselves. And of course, a very interesting group, therefore I'm also here, venture capitalists. Because they are usually, what we do in the Netherlands is, they spend hundreds of thousands of Singaporean dollars or millions. And before you kick in some investment, it might be good to know whether there's music in that investment or not, in that innovation. So the HNL report or guidance, Horizon Guide, is actually giving them some confidence that they should put their money in there, or not. So it's actually a kind of deviation, a kind of triage. Go for it, do not go for it. It's not mandated, it's a guide. Now, and I'm very proud. These are not what I'm going to click on it. These are not quotes from me, but these are quotes from the innovators or investors that came, that already did a round table with HNL. So just have a look at these quotes. It's very much, because that's actually indeed what HNL does here. We provide answers to questions they never ask themselves. We already know the questions that they're going to ask, not me personally, but the people around the table, because they know what they want. And they know what they have, and that needs to be matched. So these are the quotes. I think this describes best what a Health Innovation Netherlands is. And that's not all. We don't only provide round tables, because there are too many devices. The Netherlands is too small. We can't do this for every device that's coming around, every innovation, particularly not with AI, because AI is now everywhere, also in healthcare. So we need to actually provide infrastructures, frameworks, to the world, to the field, so they can do it themselves. And that's my next talk about AI, where most of you are here for, because we developed that AI framework as well. And then, of course, we like to become international, go to Europe, and particularly also outside Europe. And you're actually my guinea pigs. You're the very first that I start across the globe, except for the FDA. And that was my talk about Health Innovation Netherlands. We try to bring innovations to the next level. Thanks. And before I kick with the AI, I just open the floor to questions about what Health Innovation Netherlands is. Are there any questions about this part?
Thank you very much. My name is Peter Thalhammer. I'm from Roche, and I would have one question regarding reimbursement or access. Is that tied to the roundtable or going through specific stage gates so that then the industry gets access or the solution gets reimbursed?
Yeah. Now, for starters, the health insurers are around that same table, and not, again, some rookie, but actually the president, the director, the CEO of the health insurance companies are around that table. And I do have to say, like the FDA, because they have a legally ethical commitment and responsibility when they say it gets into the reimbursement system or not. So what they tell is they give an advice at that stage, but it's not a guarantee. That's what they say. So we just kicked off 2 years ago, so they do tell them, the insurance companies, what they want to know before they go into reimbursement. So, and if that innovator follows that advice of the health insurance company and the innovation shows what it promises to show, then you need to, show balls, and then if you say there yes, if you say here yes, you need to reimburse. But it's not a guarantee yet. I kicked off with my arrogance. I kicked off 5 years ago that I thought, if you say there what they want to know, it's mandatory. You always should reimburse. And we are not there yet. But I have the feeling that people are changing and they're now talking about the high NL approval. If high NL says yes, then they're going to reimburse. But that's not there yet. Is that an answer to your question? Any other questions? Your neighbor.
Hi, Prof Moons. Jermaine here from Roche Diagnostics. Thank you for your sharing. I'm curious if you can share some examples as a result of the output from the roundtable that could be, commercialized, reimbursed, and already adopted, be it, a minimum viable product in the market. Yeah.
What do you mean? Whether it's open for?
Some examples that are a result of the roundtable products that are now in the market that are adopted or reimbursed.
Now, for starters, we all have to sign a non-disclosure agreement. So unfortunately, I cannot open that. We had now, I think, 16 companies from small to big, huge, and including Philips, and even Philips, to my surprise, said, we don't get all these people around one table myself. I thought Philips controls the world, at least the Netherlands. But apparently it's not yet, at least. So even Philips has profit with that, but they all need to sign, because it's sometimes company secrets. So it's a non-disclosure. So the reports that we provide are not out there. We do have a generic template that is open, and we only started 2 years ago, so there are not yet people, innovators, that actually already got to the market. But the innovators, the previous slide showed that that were actually quotes from innovators that somebody said to me is that if HNL was already there, it probably would have saved me 2 years or 3 years before getting it to the market. But it's really hard to prove that. You don't have a control group without HNL, so to say, so you don't know that part. But in a few years, I hope I can show that the time to reimbursement is shorter thanks to this infrastructure. It's also not a program, it's not a project, it's really a change in culture. It's an infrastructure. And it's here to stay. I mean, not here, but I hope maybe here as well. And I think actually Singapore really is a country where you could do this. You're small, sorry. We are small, you too. We are both small. So we're both small. And if you're small, it's easy to organize this. I also went in Washington and I presented this FDA. And they started laughing at me. You know how Americans are. They really started laughing. Because we already have 80 hospitals. We have 85 hospitals in the whole country, only 8 university hospitals. We have that already in New York. And this is our whole country. So you can't do this easily in huge countries. But Singapore, I believe it is possible. And you have a good connection between all the stakeholders. So it might be a good example. Any other questions? 5 minutes, okay. I have to go to the next talk.
Stage of the innovation journey would the entrepreneur get the most value of sitting in one of these roundtables? Yeah,
that's a good question. You saw that bumpy road, eh? And here was the CE, the market access, and there. That experience I do have. We had done 18 tables now. There are 25 in the coming months that are planned in, more or less 25. Not only COVID, by the way, also COVID. And pre-CE is the best for them. Because then you can not manipulate, but guide them as early as possible. Because our second table was a robotic, by the way. I can't mention names. And there the final result of the round table was, stop. Stop what you're doing. This will never be in our system. It will never be reimbursed. And they weren't happy. But a few months later, they came back and they were happy, actually, because they stopped their chain, and they went on something else, still in robotic, but not on that part. And it was also pre-CE. And it's very unhandy, and that's unfortunately the tech push. People simply continue, And they continue, and then here they suddenly come around, oh my goodness, nobody was waiting for that robotic. You know the Da Vinci robot? We have 26 in the Netherlands, if not more. And the question still is, there was a report came out a while ago, not so long ago, we didn't need 26. And we could have known, it would be perfect if we had known that there. Yeah. So both, but the earlier the better, of course. Yeah. And the table is matched to the position where the innovation is. Is that an answer to your question? Shall I quickly move? No, one last question. To the next.
Yeah, I used to work in a research laboratory, and we have this idea of market-driven research life cycle. So in that life cycle, the important thing is even to begin a research topic, regardless of which field, you have to identify the problem statement, and so on. So from the round table, how many of the problems could have been given by those partners even before the entrepreneur started the project? Because it's a lot of wastage.
That's a good question. Who am I to change that? Except that it's a little bit related, this question. The earlier they are there with the ID, the better we can shape it. I just talked about that other big multinational. They also had an innovation already quite evolved. They already had CE, and they thought, we know the problem, and we change it. Actually, we make the problem, more or less. But that's not how it works indeed. The medical context is not determined by usually a company, but it's actually determined by the patients, the citizens, depends on. And getting that message, that's actually what exactly the HNL table does. So the healthcare professionals and the patients are one of the most important ones. The earlier, the better you know, and the better you can tailor. Yeah. And that's what we try to send that message. Talk before you start doing that whole part. Yeah. Now, an AI is even the worst. In that. Now, let's go to the next talk. Yeah, just a few more minutes on AI. Can I go to the next presentation? So the next talk is about, and it's AI, and I told before about that you need frameworks to assess. I mean, as I said, there are frameworks for medical medicine, but there are not frameworks for imaging devices. We know a little bit how to do accuracy studies. They're not framework how to evaluate implants. The same as medical drugs? Yeah, we think so. That's the reflex usually. We're not sure. They are not really frameworks about point-of-care testing. And definitely they are not frameworks about AI algorithms. And therefore, based on AI innovations that came across with HNL, the Dutch government from Ministry of Health said, we also need a framework that right now, because it's going too fast. And that's why they asked me, or actually I volunteered. I can lead that initiative, AI for Health. And that came out with this quality guideline that was published in Nature Digital Medicine, and then it became a formal guideline, which is in English. And again, it's a guideline. It's nothing mandatory. It's up to you and up to the world whether or not to use it. But in HNL, we use this framework now. AI is in imaging recognition, pattern recognition in omics, for example, in pathology. And another big field is AI that we include in our prediction algorithms. And prediction algorithms use machine learning or deep learning. Yeah, here we go. And I'm focusing on that part, prediction algorithms that are based on AI. Now, this is my main work, prediction algorithms. I started with drug research, but I actually got my career. It's a good point. Stay in prediction algorithms. Prediction algorithms will be the future of medicine. Not so much drugs, but it's particularly prediction algorithms. So this is Dutch, but it's the Ministry of Health, and they had this program, Valuable AI for Health, and I was the one taking on that for prediction algorithms. Now, why did we do that? That was one of the questions I got beforehand. It was already in the slide, because the whole world says, and this is just one paper, machine learning, one form of AI, will change medicine, will change the world, so it will also change medicine. Whether you like it or not, it will change us. Now, doctors can better be replaced by AI system because they're also much less arrogant. Probably that's true, by the way. And there were success stories, of course. AI actually beat the Go championships. And of course, we all know this. IBM Watson in the early 2000s. I think it was even earlier than 2011 when they did that. And indeed, they beat the human being there. And therefore we said, okay, let's focus on IPAs, AI-based prediction algorithms. I will tell you what we mean with a prediction algorithm. So we made a review of the existing literature and guidance that is out there in the world, and that was published in Nature Digital Medicine. Very recently, by the way, you're one of the very first that I present this guideline to, at least face-to-face, the very first. And that, there's an arrow there, that review led into a formal guideline in Dutch and in English on how to assess AI-based prediction algorithms. Now, what is a prediction algorithm, whether you have AI or not? Prediction algorithms are already out there in medicine for decades. I will show you for the first. Now, what is it? It's any combination of two predictors, and predictors can be other words, variables, covariates, determinants, input features. AI people usually use that word, input features. And to convert that information to some probability that a person has the disease right now, that's called diagnosis, or that they will develop some event in the future, and that's called prognosis by definition. That's in the words. Pro means in time. And that's what, and actually you don't need necessarily to be sick. Everyone who is at risk of developing an outcome, on your iPhone you can access thousands of prediction algorithms to see what you have right now, what you will develop in the very future. Do you know what the very first prediction algorithm in medicine was? Anyone? And I'm sure you know. Even though you don't know, you know. Yeah, very good. Yeah, Virginia Epker, 1951, in JAMA. There was no eye involved. There was no machine involved, actually. She did it in her backyard and simply had 5 items, 0, 1, or 2. 0, you have a very poor prognosis, the newborn, and 10, you have a very good prognosis. And this is applied all across the globe. It has been validated, tested, evaluated across the globe, and it does very well. In every newborn, no matter what race, what color, it always seemed to work. So that was the first. And then we kicked on. This is the framing and risk score, or the score in Europe, and in the UK, it's, in the America, it's the framing risk score, where actually you have a few parameters, whether you are woman or man, smoking or non-smoking, and that leads to a probability, which is the numbers of getting a cardiovascular event in 10 years, etc. And actually, what you can do right now, if you're already bored by my talk, sit back, relax, go to your computer, and you can go to the internet to get prediction algorithms to predict whether you have cancer right now or whether you get it within 5 years, whether you have diabetes or will get it. You can do it. Just start doing it. There are thousands of out there. And if those risks are low, you can then actually check when you're going to die. There are many probabilities. And if that risk is also low, you can also check whether your bank is going to get bankrupt. It's all out there. Prediction algorithms is overwhelming medicine already for decades, before AI. And this is the number of prediction models that we have in medicine. There are more than 400 models right now, more than 500 for cardiovascular disease. Which one to use as a doctor, as a patient, as a civilian? We have no idea. And we develop them because we can. We have data, we have a machine, let's develop them. And this is all before AI. So why did we now come up with this IPA quality guideline, AI-based prediction algorithms? It's because every healthcare prediction modeling seems now to be redeveloped with AI. We already had them, and we are now redeveloping them with an AI machine learning approach. Why? Because we have data, and big companies are in there, so let's redevelop them. Let's see whether they are better than what we did already. So we have a lot of data and software-driven prediction algorithms in health, but they require a quality check, an applicability and a validity assessment before we are using them. And that means we need to have some guidance. And suddenly also, everybody makes IPAs in healthcare. even these companies, here just a selection, here you see their names, they are in yellow. All medical papers with big companies, because they have a data set, they are really good at machine learning, by the way, really good. So why not develop a prediction algorithm in healthcare? So we get a different play field with different players, so we need to act upon that as a society, I think. Okay, so AI is suddenly everywhere in healthcare, and COVID made this clear to us. Now, I had the very luxury to lead this global initiative. It's a living review. It comes out in BMJ every 6 months. It's the very first in history that the BMJ does it. BMJ is not a local journal. It's one of the big journals in healthcare. So they asked us to do this review every 6 months to update it. Do you have any idea? How long is COVID among us? 2 years, 2.5 years? A little longer here than it was in Europe. Do you know how many prediction models, prediction algorithms for COVID were already developed in the past 2.5 years only? Anyone? Like an auction bid. Eh? Now, not 10,000, because then I probably wouldn't be here, I was there. But it's more than 2,000. It will come out very soon, and the fourth update will be in the BMJ very soon. More than 2,000 prediction algorithms for COVID, and some were developed on 12 patients. 12 patients only. Why? Because they can, and we have data. So why not develop a prediction algorithm? And I'm not sure whether the world is really waiting on all these prediction algorithms, but we can. I can, you can, we all can. So therefore we thought, the government thought, also the companies were part of this, thought, let's start making some guidance. And we did that together with the Ministry of Health. And let's first start the scoping review. So this is again what an IPA is, the definition. A data-driven model that provides an individual's probabilistic prediction of a current presence, diagnosis, or a future occurrence, prognosis, of some outcome, giving certain input features, etc. Now, why did I volunteered? I said in the Netherlands, I will lead this nationally, but I already lead a large consortium internationally to come with an international guideline. It will be probably next year. So I said I can do this also in the Netherlands, because I did this before already, many guidelines for prediction algorithms without AI, and we simply moved on by including how to do it for AI. And we also wrote a book on that. And of course I thought, I used to call it statistics, and nobody came to watch, but as soon as you put artificial intelligence under it, you suddenly have a lot of viewers. So it's very good. If you do, it doesn't matter what you do, say you're in artificial intelligence and you get viewers, so that's good. So what are the phases? What we first did is just check all the institutes across the globe. What quality assurance guidance do they use? NICE, FDA, companies, etc. So what we did, there were 6 phases we defined. Is preparation phase, the development, the validation or evaluation phase, the development of the software application, the impact assessment, to what extent do they change, impact healthcare? I see the time, yeah. And the implementation phase. So we defined these 6 phases. Don't read this whole slide. And then we went into the literature. We not only checked PubMed, but also we went to companies, to their quality tools that they use, the big companies. We also went to the guideline organizations like NICE, FDA, and some others, the big ones in Europe. And we came up with 72 reports, not papers, but reports. We all went through them. It was quite a job, I can tell you. We all went through them, and here 75% were developed by academics across the globe, 24% by companies, and 26% by institutions like NICE, FDA, etc. And what we did here, it's very short because the paper is in the open field, is what we did. 72 references. We had these 6 phases where we defined per phase the most important topics that AI in that phase should go through. We had 138 keywords that we divided across the 6 phases with their subtopics per phase, simply to help you to see, okay, if it's about privacy, I need to open these guidance tools. If it's about software application, I need to open these guidance tools. So per topic, you can go directly to the references and the guidance that was written there, summary, of course. And we had 6 overarching topics, which is very famous. The ones who are in AI know what this is. Algorithmic bias, transparency and openness, interpretability, who are the end users and stakeholders, security is a big thing, of course, and the risks of using AI software for prediction algorithms. And we simply mapped this whole field into easy accessible figures, just a very short how it looks like. So here the topic 1 was about data preparation. Here is the medical context and problem definition, and here are these 6 overarching phases. So per topic and per aspect of AI development, you see what it covers and also which references per topic can be viewed at. And of course, we gave a summary of all these different topics in that paper that is now published in Nature Digital Medicine. So that's what we aimed at and what we did. And I quickly go through these slides because you can download this. We can better have a discussion. And then the next step, when that review was published in Nature, a publication doesn't change the world, particularly not in the Netherlands, we know. So you need some assessment that the people around the high-NL table can use as a, how shall I say, as a kind of flow chart. What do we need to check if somebody with an AI algorithm wants to enter the healthcare market and really want to get where they want to be, and not simply launch it somewhere, because there are thousands, 10,000 of AI innovations already in healthcare. So we said we changed this review to a national guideline. And here, this is, yeah, sorry for the Dutch, it's not yet translated. It's www.leidraad.ai.nl. And there you can actually download the guideline, which is also in English. Now, very quickly, what did we do? We took that review and we selected about 60 stakeholders from the Netherlands and outside the Netherlands, from all these people that are involved in AI. So companies, AI experts, patients, doctors, governmental and policy organization. Per phase, we had working groups. That cost about 1.5 years, we did that. And we simply went through all these quality tools and criteria that they thought are needed, and they were written down in this guidance. So it's a guideline developed by the field, for the field. That was the idea. And the starting point was the review and, of course, available knowledge. And we think that it will improve the quality of our health care, but also economic profit, because I developed many prediction algorithms in my life already, and just a few finally made it into healthcare practice. And how good would it be? You probably all are dreaming to having, at least let me tell my dream, the Moons model for whatever, I don't care. If it's a Moons model, I'm happy. Like Virginia APCAR, the Wells model, the APCAR rule, it would be great. But that is not how it works. It only works if the people over there like it and will use it, of course. Now, it's not legally binding yet, but it is relevant because it describes what is considered as good professional conduct as an innovator, as well as a user or as a healthcare professional. Now, what do we say? We say comply to it, or if you don't comply or cannot comply, at least explain then. Just tell the world what you did. So we have requirements and recommendation. Requirements means almost mandatory. The field wants to see that. And recommendation is, okay, we don't require it, but please, we do recommend to say something about the privacy, about the open access of the data, the open source of the code, etc. Are you still with me, or are you sleeping already? Okay, and that's what it is. So what we did, these are the groups. So the groups are not only the healthcare professionals, these are the stakeholders. So the people who develop AI, apply AI to the left. Now that's easy. And don't forget, you too. Everything you do, you have, perhaps you don't know, I do now. Everything we do here is based on AI, but also there are many prediction algorithms that you might have checked already once in your life or will check in due time. And usually there's AI involved somewhere. So it's good to know that you are a very important stakeholder as a citizen, even though you're not sick yet, but still you use AI. The ones who develop AI definitely can profit of this guideline. The ones who assess AI, policy organizations, and society at large, of course. Now, what did we do? I already said this actually, so we'll skip this. So what we simply did is, again, these 6 phases, we gave simply criteria, mandatory and recommendations per phase, per topic, that we like to see for an AI and innovation. Again, it's not mandatory, it's not obligatory, because it's just a guideline yet, but at least what people like to say. And again, it's in English. And I think it's not very different in the Netherlands as it is in countries outside the Netherlands. And this is what we have. So it's guidance per phase. We have an e-learning module and a community building. It's also on LinkedIn, where you can actually ask questions. And currently I'm in close contact with the Dutch government to implement the guideline into the Dutch system and to disseminate and to ask them, does it work? Do you miss anything? Is it too complicated? What do you miss? Do you need education? Because I think education is the most important part. I did also in healthcare education in the Netherlands years ago, but the word AI was never there. And actually, even in many educational programs across the globe, I'm sure that AI doesn't have really large modules yet. So we need to improve the education of our healthcare professionals and even, I think, of our citizens. And that's what next, and here are a few links, of course. Now, thank you very much for your attention, both for the high NL discussion and for the AI quality assessment. And I think the floor is open for a Q&A. Yeah. Thank you very much for your attention.
Thank you, Prof Moons. And now I'll invite us, Suchi on stage.
Let's make this executive decision here. I think we won't have time for a fireside chat. And rather than my questions to Prof Moon, I'd rather open up to the audience for questions, so the limited time that he has before lunch. And what I will do is let me look at the online questions and pose some of them to him as well, okay? If that's all right.
There's an online part.
So we have an online Q&A system if you want to use it, and then Suchi will look at the questions through there. But in the meantime, if anybody in the audience has any questions, feel free to raise them, and I think Prof Moons will be more than happy to answer them. Yeah. Anyone has any first questions for Prof Moons, maybe?
Was it that easy, or have I lost you? Are you asleep?
I had 30 questions for you, but this is just my perspective. Sorry? Yeah, why not? Why not? Okay. So I'll give the audience some time to think through their questions. But firstly, thank you for both the presentations. Very inspiring, honestly. So I come from a perspective of robotics and AI, but very inspired. So you've helped shape your country's guidelines on AI development and adoption in the healthcare field. So curious to understand, where did this all start? What was your team's objectives and motivations when you started to embark on this kind of project?
I can be very short on that, is that prediction algorithms are out there in medicine for decades, and it was exploded. And then we found out that AI is repeating everything or redoing everything. So doctors and patients and citizens are suddenly faced with numerous prediction algorithms based on AI that were already out there. And we have no clue how to separate the chaff from the wheat. Where is the music and where is the noise of all these algorithms? And the Dutch government also realized that, because usually companies go to the Dutch government trying to get somewhere in the system. So they were sitting with their hands in their hair. That's a Dutch expression meaning, yeah, how can we guide this? And therefore they thought, let's embark on some guidance based on what the world already has produced, of course. We didn't invent many new things, we just brought it together.
Right,
Yeah.
right, fair enough. And what were the, I think I'm good, what were some of the key considerations that you took into account while shaping it and developing it in terms of the direction that the guidelines should go towards?
Yeah, now that was also easy. Make sure that all the stakeholders around that table, because what I found out, what HNL needed was all views in the room. We needed the whole system in the room, all stakeholders in the room. So not only the developers of AI, but also the users, the reimbursers, the policy organization. So that was the most important thing. Get them in the room, because you need them all. You can't push.
But getting them in the room also means getting 20,000 different expectations and perspectives. So how do you manage?
Yeah, the room was a little smaller than 20,000 people. We didn't have an arena, but it was, yeah, you do know the stakeholder organizations. It's not that many, the companies, but you need the really representatives, the figureheads of these presentations. So we invited them in the room, but indeed it was 60 people, but doable.
In the context of public sector, private sector expectations, you know, and outcomes that they're looking for might be distinctly different. So how do you match?
Yeah, that's a good one. And that was also HNL. So everyone heard the question, how do you match the expectations from the...
Can people hear me? Yeah, okay, I'll use the microphone.
What she said is, and that's a good one, the expectations and the outcomes of companies are totally different than they are for healthcare professionals and the policy. And actually, if you're longer in this system, and you all know this, I don't say anything new, we know this, but what does a company have if they have an innovation and they get to the market and nobody uses it? There's no economic profit, I can tell you. The only economic profit is not to get to the market, no, it's to make sure that when it's on the market that somebody uses it, and not only one person, but everyone. Yeah, that means that you don't need to get to the market only, but you need to know what they want. And again, in economic products, it's different. You can push and you can change. But in healthcare, you can't really change it without the patients and the doctors that are part of healthcare largely. So you help each other. Their outcome is make money, and their outcome, they don't care that much, and they're not against that somebody makes money on it, but at least on things that they need. And match these two, that is actually profitable for both. Even though the outcomes were different at the beginning. Yeah.
Fair enough, fair enough. Are they, yes, there's an audience question here. From Roche Diagnostics.
Hi, Prof. Just curious whether the patients group, as well as the payers, being insurers, government, have actually articulated what would it take for them to have that willingness to pay for such predictive model. Now, the question stems from the fact that, you know, such predictive models that we have been using, like the Apgar score, as well as severe risk, even COPD, you know, staging, has always been free, right, for clinicians to use. So just curious, what would it take for the payers to see that, you know, what sort of value or even what sort of therapeutic areas that such AI algorithm must be in for them to sort of have the willingness to pay for the solutions? Yeah, thank you.
Sorry, what was the last part, the actual question? What was that?
So the question is whether the patient group as well as the payers, like insurance company, have actually articulated what it would take for them to be willing to pay for such AI algorithms.
Yeah. Now, that's a good thing, and therefore you needed all these stakeholders, because a lot of AI is actually meant, and also the vice ambassador said it at the beginning, the healthcare system is changing. We go for intramural in the hospital, outside the hospital. But a lot of AI, prediction algorithms, are developed somewhere and used and disseminated, issued from hospital care providers to prevent that people come to the hospital but stay longer at home. So that changes the healthcare profits, and actually the benefits are not for the ones who issue the prediction algorithm, which is the doctors in the hospital, because they don't get less patients to the hospital, so they have less money in their pockets. And that's interesting, and that's an important thing with AI algorithms. So patients want something to keep them out of the hospital, including insurance companies, because they love to, the less they need to reimburse, the better it of course is. It's logic, and there's nothing wrong with that. That's simply how the system works. And there, yes, the doctors say we don't want you in the hospital, but on the other hand, you need to do something about the reimbursement system for the people in the hospital. So the patients were simply there, and what's in it for them is to make sure that the algorithms that are going to be used for them in the prediction of the future or their health outcomes, that if they are issued to them, for them, they need to be sure, and actually I want to be sure as well, that that algorithm indeed is better than what I do now, which is otherwise going simply to the hospital. Okay, it keeps me out of the hospital, but if I really have something, I want to go to the hospital. And that's, I think, where the citizens and the patients have their big benefit to sit around the table and determine, ask innovators what really is the impact or effectiveness of using an algorithm for them. Because without these algorithms, the system stays as it is, and probably that's not tenable. At least in the Netherlands, the healthcare will be too expensive. We get older, more disease, we can't all go to hospitals anymore. So we need to move healthcare with AI algorithms outside the hospital, but then we need to be sure that their quality is good. And not because they are there, but they really are good when they're there. Is that an answer to your question?
No, thanks for your perspective and for echoing patients. So I guess in the end, it's still patient centricity, right? As long as the two fits. Yeah. Thank you.
Are there any more questions from the audience? Yeah. Okay. Maybe we'll go with you first because the mic's closest to you, and then we'll pass it to the back.
Does it work? Yeah, perfect. I would have one quick question. As you said, it's very important not to bring something to market, but to bring something into clinical practice, some algorithm into clinical practice. How does the assessment help to get, for example, algorithms, if the evidence is provided, into clinical guidelines? Is there this last step also somehow supported, or is there an interface to this last step to get something into guidelines?
Yeah, that's a good question as well, because almost in many Western countries, is as soon as something that you developed is in the guideline, clinical guidelines, I mean now, eh? You mean that too, eh? Yeah.
Yes.
If it's in the clinical guidelines, which I'm sure Singapore has and all the Western countries have, as soon as in there, they're going, healthcare professionals and therefore patients are going to use that. Now that's the exact reason why around the high NL table, the stakeholder representative of these guideline organizations are actually one of the members around the round table. So they give that same advice. They tell the innovator what they want to see before getting it to the medical guideline. And to do that, you need some guidance on how to develop for AI. Is that an answer to your question?
Yes,
They're
thank you
involved in the process. They have to be. I agree.
Yeah, perfect. Thanks.
Thank you. Could we have...
Hi, afternoon, Prof. Thanks for making the trip and sharing your insights with us. So my name is Desmond. I'm a patent attorney. I'm curious with regard to your comment earlier that some of the models that your committee has assessed has a sample size of 12 subjects. So coming from the perspective of assisting my clients, because of course 12 subjects means that there's a lower cost for them as well. Does your committee discriminate against a more cost-effective model generation algorithm? Do you straight off say that sample size is so small, this is not so desirable?
Yeah, it's a more detailed technical question, but fortunately that's my own field of research itself, so I understand your question very well. We give explicit guidance on sample size, on how many individuals you need both for development and for testing or validations called evaluation. So there are really explicit guidance, almost on the numbers. is in that review and also in that in that quality assessment guide, and also how to select input features and the chances of over-selecting, over-presentation, over-fitting, because that's very dangerous in AI-developed algorithms, that they are very good on that small data sets, but if you use it outside that data set, they suddenly drop in the accuracy. And that's what you want to know and test. And how to do that, these guidelines, and what steps you do, that's very well explicated in that guideline. Yeah. We already did that. I wrote numerous papers and also books about that without AI, and actually with AI it doesn't really change much, to be honest. It's almost the same. It's just another method.
Thank you. There was actually one question at the back, and then I'll come back to the gentleman in blue, if that's all right.
Thank you. Good afternoon, Prof. I'm April from Icadium. We're an AI startup, and we're looking at translating AI governance principles into practice. And I wanted to get your thoughts about whether there are new pain points that you are seeing from the transition between predictive algorithms to AI in healthcare, in terms of how the medical vendors or even healthcare providers can verify things like transparency, explainability, safety, given that AI models are a lot more dynamic. Model drift can happen the moment data changes. So what might be the new pain points arising?
Yeah, that's a very good question. Actually, currently, I said this before very quickly, I'm working on I'm leading a large international consortium that comes the explicit difference between prediction algorithms in the old days versus with AI and machine learning, the differences and where are the peculiarities about it. But just to give it away a little bit already, because it will be out there very soon. On July 5, we have the last consensus meeting across the globe. And I mean, it's online, but very quickly, you also already mentioned them. Now, in the past, somebody simply developed a model with a formula. And that formula was out there. We understood it. It's simply, APGAR score was really simple. It's 0, 1, 2 with 5 items. So you don't need a formula for that, by the way. Every individual can do that, from 0 to 10, counting. But the other models simply had a formula, usually a regression formula. So you simply could take that from paper, and could put that somewhere in your Excel file or whatever, or that score chart that I showed with the colors. There's a simple underlying formula for that. AI is different. That formula is not so easy because it's a totally different tree structure under that. So it needs to be, doesn't need to be, but it helps if it's transparent. What's the underlying mechanism formula? What are the underlying input features? What is the, mention a few things. AI, unfortunately, is very often developed on data sets that were not developed with a purpose, but simply out there. Routine care registry data, but we have no clue why that data is collected to some individuals and why not. Whereas in the past, prediction algorithms were based on pre-designed, prospective studies usually, data sets we knew and understood. Very different with AI. And explainability, it's recorded, huh? Everything I say is recorded, huh? Yeah, okay, I have to be... Explainability, yeah, that's an interesting. I'm working now on a paper where, and the title will probably, Explainable AI, Don't Bother. And that's cursing in the church, I know. That's a Dutch expression that means I shouldn't say that. A lot of people don't agree with me, but I was once, and then I was a key lecturer in a congress, and the other key lecturer was Erwin Krol. And Erwin Krol is the weather forecasting person in the Netherlands for decades. You only had one, and it was Erwin Krol. And I was first. And I showed how medicine works with prediction algorithms, with APGAR and everything I showed. It was a little bit before AI, a year or 6 ago, something, 7. And I showed, and I thought we really do a good job in medicine. And I showed them the formulas, etc. And then he was after me, directly after me, without a break, and he kicked off, laughing, "Carl, is this really how you do it in medicine? Why do you want an explainable model? Why do you want to see that formula like APGAR? Do you think that I understand how we forecast weather, do you think that I understand, oh, the wind is that direction, gets a few that gets this way, the temperature is that gets that way, okay, the speed of the wind is that high, so that gets that weight, the humidity, etc. I have no clue how that whole formula looks like, how to explain it. I understand it. What I need to know is whether the result, the prediction whether it's going to rain or not, the prediction whether you are diseased or not, the prediction whether you get the disease or not, whether that probability or classification is correct. And the underlying thing, do I really need to explain that? I never can, and I will never will be. So why do you want it in medicine? And probably that is because we like to have some face value, but the question is how much face value do we desire of an AI model? But we need to test whether they're correct, and I think that's very different. That explainability thing, demand for AI, that is much more than it used to be, and I wonder whether that's a correct difference, whether we should focus on that too much. I'm not sure. Some black boxes doesn't matter. Do you have any idea how they forecast the weather? No. And they're good. They're really good, particularly here. It's easy, by the way, here. It's always 30 and it's always humid. So even I can do that. So these are oh yeah, and by the way, the selection of the input features. That's also very different. That's the other question. And so these are the 5 elements that are very different from the past. And we will explicate that very carefully. Is that an answer to your question? Yeah.
In the interest of time, I might just take one last question from the gentleman in blue.
I want to ask a tangential question, and that is, how do you view APA being applied for humanitarian purposes, especially like the African continent and so on? Because there is this concept, a friend of mine who is in UNDP developed as the medicine without hospital. So I think that there is a lot of relevance in it, but how do you link the two together, if at all?
And link exactly which 2 parts together?
Link the use of AI and predictive medicine in the context where there is no hospital, there's no modern medical facilities, but you can actually get a lot of good results by applying that knowledge for the community who are too poor to attend, to go to hospitals, to see doctors, and so forth.
I'm not sure whether I understand the question. You mean how AI will be implemented in daily care?
Yes, in a GP context, rather than specialized medical conditions.
Rather than going to the hospital, you mean?
Yes, that's right.
Whether that's better or not? How do you?
Whether you can apply in, say, in the African continent, where it's very difficult to get the necessary care.
Yeah, indeed, that phase 5 is about impact assessment, whether the use of these prediction algorithms are better than what we do now. That's not easy to evaluate that. And in the past, we usually did simply comparative effectiveness studies, but we can't do that for every AI algorithm. There's simply too many in the world. And we don't have enough human beings to test them all in randomized trials. So we have to do it in other ways. But I think we only need to do that from those where there is some music in it. So we had to separate the chaff from the wheat. And then there are good ways how to, and it's actually in the guidance with the references. It's not my invention. People have written a lot about it. How can we implement some prediction algorithm, whether it's in the hospital, primary care, or even for you and me at home? How can we implement them and evaluate that they are better than what we did, than the current situation? And that's actually, that is doable. You can make like HTA assessment, cost effectiveness analysis, the current healthcare and all consequences, and you have the new healthcare, you monitor that for a short while, and you can compare the two to get a hunch, a good hunch, an estimate of whether it's better than what we do now. So in my view, it's easy and it's doable. We just need to demand it for those algorithms that we really are going to implement. And again, by the way, to be clear, I'm not talking here about algorithms that say, oh, you are sitting already too long, do a little walking. Just do it. I mean, don't evaluate them. It's, you know, like jumping out of an airplane without a parachute, don't do it. Just wear the parachute. But if it's algorithms, and you have type 1 diabetes or type 2 diabetes, and you go home, and there's an algorithm that tells me your sugar is too low, shoot insulin, then I want to know. By definition, I want to know whether that algorithm is correct, rather than what I did now, namely testing myself, going to the doctor and get some extra insulin. You don't want to have a hypo. So it depends on the consequences of the prediction algorithm that demands or should demand a more rigorous evaluation approach before implementing it. And that's what that guidance shows. But that doesn't mean that everything needs to be randomized trialed. Is that an answer to your question? A little bit? Indirectly. I'm too long on politics now, probably. Always get indirect answers. That was not my intention, though.
Well, thank you so much, Professor Carl Moons. We really appreciate you spending time here with us. I know you're here for some other meetings, and we appreciate the time and apologize to everyone, the audience as well, that we've run over, but I know you all want to make the best opportunity of having Prof Moons here, so thank you again for spending extra time with us. On that note, also want to thank the Embassy of Netherlands, the Netherlands Innovation Network, and the team at SG Innovate for organizing this session and really democratizing availability of brilliance into us. So thank you so much. Let's give everyone a round of applause.